Welcome everyone. Welcome and warmest greetings to all participants, speakers,
Repertory.
and committee. Very pleased for all of you to be able to join us again in the second session on Nutri Spiritual Symposium 2020, Nutrition Battling on Pandemic COVID-19, How to Survive. I would like to invite our dearly beloved Dr. Dian. Hello. Hello.
Okay.
Okay, sorry. Once again, welcome and warmest greetings to all participants and speakers and committee. Very pleased for all of you to join us again in the second session of Nutri Virtual Symposium 2020, Nutrition Battling on Pandemic COVID-19, How to Survive. I would like to invite our dearly beloved Dr. Dian Permatasari as our moderator for today. Dr. Dian Permatasari is a Master of Nutrition, Clinical Nutrition Specialist, and she currently works in South Tangerang General Hospital and Hermina Ciputat Hospital. She is also the chief of Banten branch of Physician Nutrition Specialist Organization. She is also very active as a health promotion speaker. To Dr. Dian Permatasari, the time and panel are yours.
Okay, thank you, Dr. Kitara, for the introductions. Good afternoon, everyone. First of all, I want to thank you to Indonesian Nutrition Association for having me again as moderator on this webinar series. Today, I will lead the webinar and we will have three sessions. First session is Iqbal Mustafa and Javier Laber Memorial Lecture. Second session is I'm sorry. Thank you, Dr. Pitara, for the introduction. Good afternoon, everyone. First of all, I want to thank you to Indonesian Nutrition Association for having me as moderator on this webinar series. Today, I will lead the webinar and we will have three sessions. The first session is Iqbal Mustafa and Javier Laver Memorial Lecture. The second session is sponsored by Fresenius Kabi, and the third session is the clinical nutrition session. So without waiting any longer, we will start the first session. In this first session, we have two speakers. The first speaker is Dr. Abdul Reza Nurozi from Mashhad University, Iran, with the topic nutritional support in critically ill patients. And the second speaker is Dr. Aman Pulungan, pediatric consultant in endocrinology from Indonesia, with the topic sustainable development goals in children during pandemic COVID-19 in Indonesia. Dr. Reza will speak for 20 minutes. After Dr. Reza presented his topic, we will continue with discussion time for 10 minutes. For the participants, if you have any questions, please type your questions in Q&A column and I will choose the questions that will be answered by Dr. Reza. And now for Dr. Reza, the time is yours. Please, Dr. Reza. Okay, Dr. Reza, good afternoon, please.
Hello.
Hello, Dr. Reza. We can hear you loud and clearly. Hello, Dr.
Hello,
Reza.
Dr. Reza.
Hello, Dr. Reza. Hello.
I think Dr. Reza had a technical problem in share screen.
Team ICM team, could you please help? Dr. Reza? Hello? Can you hear me? Dr. Reza?
Dr. Reza seems now join the audio. Maybe you can leave the room first and then join again, and then join the audio, doctor.
Hello.
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 Hello. Hi. Sorry, I just connected just now. Okay. So I have to go to my slides. Um, Sorry, could you please tell me? I just forgot. How could I go to my slides? There is a
In the
Can
bottom, it's in the bottom of the
the
Zoom.
bottom in the middle, there's a share screen.
There's a share screen. The button is
share screen. Yes.
yes.
Mhm. Oh yes, I found it. Yes. I'm sorry. I don't know what happened. I can't.
Dr. Reza, could you please open your presentation first?
Okay. I open my presentation. Okay.
Open the presentation first. Yes.
Okay,
Okay.
you can press the slideshow.
Okay.
Okay,
Yes.
yes, please, Dr. Reza.
Okay. Thank you very much. Okay, I would like to say hello to everyone. I hope you are having a good day and a good conference. We will have a good conference today. I would like to thank Lucy for invitation and for arranging for this conference. This week I'm going to have today is on nutrition support in critically ill COVID-19 patients. Mainly I'm going to talk what should we do for these COVID-19 patients who are admitted to hospital. So I'm starting with a small background and a small introduction. We are just having a phenomenon number of the patients who are coming to hospital and who are having been admitted to hospital. The number of the ICU admitted patient has been increased dramatically, and the and it caused lots of problem in our ICU. Many countries, many places, like in Iran, which we had a huge pandemic of the critically ill patients. The hospital and the health system should have set up some sort of like a military hospital to have some temporary extra ICU bed. Okay. So why it is important for us to why it is important for us to consider nutrition in COVID-19 patient? The primary
I'm sorry,
problem
Dr.
in
Reza. I think your topics, your screen.
okay, you're not having my screen.
Yeah.
Yes,
Okay, let me check to see what. Did you have my voice?
Yes.
yes, we can still clearly see you and
We can see and hear you
yeah.
clearly, but you, but your screen is gone.
Okay, let me open the because my screen I can't see myself. Let me check it again. Okay. Do you have my slides now?
Okay. Okay. Let's
Yes.
go.
Okay. Okay. So I was talking. I'll go a little bit further back. So the disease primarily involves the respiratory tract, but the problem is that usually 4 to 8% of the patients they deteriorate, and the deterioration ends to a multi-organ failure, and this failure happens as a acute renal failure, as it's a gastrointestinal failure, which I'm going to talk about it in next few slides about what should we do. And this acute respiratory, and another problem with this acute respiratory complication is usually the number of days that patient ends to stay in hospital is longer than usual. For example, the average day of staying in in ICUs usually is around 3 to 5 days. In COVID-19 patients, the number of the days usually patients stay in ICUs is more than 10 days. So staying longer, they need more nutritional support, and the nutrition problem would be much higher. For example, in a study which has been done in New York, in America, 42% of the patients who admitted to the hospital, they develop acute respiratory distress syndrome, and they remained on mechanical ventilation for an average of 10 days, which is quite a big number. In this study also, it shows that 40% of the 40% of admitted patients with the COVID-19 to hospital, they end up to go to intensive care unit, and 12% of these admitted patients actually they needed mechanical ventilation. And as I said, we have problems such as acute renal failure and multi-organ failure. 3.2% of these patients in New York hospitals admitted with COVID-19, actually they need renal replacement therapy. The most important thing for us that we should consider in COVID-19 patient from the nutritional point of view is malnutrition. Cause of ICU and disease-related malnutrition includes reduced mobility. As I said, the number of the days patients usually stay in the hospital is longer than usual. The patient, they usually, because of the problems with the distancing, with isolation, usually the mobility of the patient, even in the normal wards, in the general ward, is very low. The catabolic changes, especially in skeletal muscle, due to different things, for example, reduced food intake, the reduced mobility, and also increased inflammatory cytokines. It causes losing muscle mass, and this losing muscle mass, losing fat-free mass, it's going to end up the patients with the malnutrition. So with loss of skeletal muscle mass and function, which it is going to cause a poorer quality of life, and also it's going to destabilize the patient, both in the longer term and also in short term in ICU. So what's our intervention? What should we do nutritionally in the patients, as from the introduction I told you before? Appropriate nutritional assessment and treatment we can follow as achieving these goals. One, reduce complication. Second, improve relevant clinical outcomes. These relevant clinical outcomes, maybe if we categorize them as improving patients' breathing, improving dependency to mechanical ventilation, and so many other clinical items. Also, we need to reduce the ICU stay. We need to reduce the number of the days patients stay in hospital. So reduction of the hospital stays and ICU stay is another goal of us. And also, we should have special attention to older adults. It has been shown that the around 56% of the admitted patients to ICUs are patients older than 65 years old. And the patient, one of the main problem with the older patients, especially patients above 75 years old, is malnutrition. So the patients, they have malnutrition already, and they are hospitalized, going to the ICU for a longer time, and the problem with the other comorbidity and the malnutrition is going to get worse if we don't do any intervention. So what's our first step of nutritional management? So the first step is diagnosis and treatment of malnutrition. So as any other nutrition intervention in hospital, in patients we are admitting to the hospital, we should pay attention to diagnosis and treatment of malnutrition. Either patient having malnourished on their admission to the ICU or in the hospital, or patient they are at moderate or high risk of malnutrition. There are two different things we should consider. Point of view would be okay, but he or she is at moderate or high risk of malnutrition. So we need to both diagnose and treat the patient who are malnourished and the patient who are at risk of malnutrition. And this malnutrition management would improve both short-term and long-term prognosis of the patient. So why we are just putting the first step of nutrition management as malnutrition? Because in my experiences in the hospital, I've seen some intensivists, some doctors, usually they don't pay attention to malnutrition, and they are looking for some magic things. For example, they say, if I give they give the patients some like a high dose of vitamin D, high dose of vitamin C, and then they forget to pay attention to the more important thing, which is malnutrition. So malnutrition first, and then we go to other point of care that we have to do. Some patients, they are in we can put them as a patient high risk for poor outcomes and higher mortality rates. First, older adults, the adults more than 70, more than 65 years old, and also polymorbid individuals. The patient, they are having diabetes, they suffer from hypertension, they have a coronary artery bypass recently. So usually these patients, they are the patients we categorize them as higher risk for mortality and for poor outcome. We have to check and we have to do both screening and assessment for this patient. So I emphasize on both screening and assessment. We have to screen them to see if they have a risk of mild malnutrition, moderate malnutrition, high malnutrition, and also we have to do some nutritional assessment. And the best way, actually, according to ESPEN, recent guidance on COVID-19 patients, nutritional assessment, nutritional intervention in COVID-19 patient is using MAST screening tool. It is very simple, it is very quick, and also it has the minimum contact and minimum time staying with the patient. So we can use the MAS, which is one of the them. Also, NRS 2002 criteria would fit very well with the patients admitted to ICU and they suffer from COVID-19. COVID-19. One of the most important thing is the subject or patient with malnutrition should try to optimize the nutritional status by counseling from an experienced professional. So mean a dietitian, a clinical nutritionist, a specialist physician. So we can't really put the thing, we can't really leave the nutritional management for a malnourished patient just for a general medical staff in the hospital. For example, we ask the nurse to do some nutritional intervention. One of the problems that many hospitals they encounter at the beginning of the COVID-19 was the isolation. So many of them, they say, okay, shall the nutritional support team with this hot contagious disease, they go to the ICUs and they see the patients, because many of the ICUs, they tend to be a closed ICU. They don't let they discharge many of the medical teams from the ICU because of the isolation. We just say for the isolation, we need a professional and experienced medical nutrition team, medical nutrition support team to deal with malnutrition in ICU. So we have to, in your hospitals, you have to see what you can do. For example, in some hospitals in New York, actually the nutrition support team, they were all in place, and only one member who would be directly in touch with the patient and seeing the patient, and then they can discuss the patient with the rest of the team outside the ICU. Or in some settings, the dietitian or clinical nutritionist could see the patients directly. So we need a specialized nutritional team. One of the most important things for the patients, especially before going to ICU, even during the ICU, but it's more important before going to ICU, using oral nutrition supplements or ONS. ONS should be used whenever possible to meet patients' needs, when dietary counseling and food fortification are not sufficient to increase dietary intake and reach nutritional goals. For example, a simple loss of appetite, a simple "I don't like the hospital food," the patient just saying. So they will make this patient eligible for receiving oral nutrition supplement. Usually, what the ESPEN recommends is A normal ONS regimen should provide at least 400 kilocalorie per day for patients, and sometimes around 15 to 20 grams of protein per day. One of the most important things about the using ONS and prescribing ONS is they should be continued for at least 2 weeks, and it is very very usual we can use them for 1 month. So don't expect just giving a small dose or a small dose of ONS or a homeopathic dose of ONS for 2 days or 3 days and expect to have a miracle in improving nutritional status of the patient. No, you need to use it at least for 1 month, and don't give up of not getting any results if in the short term. In
I'm sorry,
non-intubated
Dr.
ICU,
Reza. Your
yes,
time is 5 minutes left.
okay, yes,
Okay,
it's okay.
thank you.
In non-intubated ICU patients not reaching the energy targets with an oral diet or oral nutrition support should be considered. So if the patient is non-intubated, we can use it in the ICU setting for these patients. If the patient is not intubated, and even we just giving the ONS, but the patient is not receiving enough amount of protein or calorie, in this case you should consider using enteral nutrition or peripheral parenteral nutrition for the patient. In polymorbid medical patient, in older person with reasonable prognosis and which energy and protein requirement cannot be met by oral feeding, using enteral nutrition is very very normal and is advised for patient. Parental nutrition only should be used when we cannot use enteral nutrition for any other reason, or even with the enteral nutrition we can get the target for our nutritional requirement. Usually the timing for the nutritional for enteral nutrition is we have to start 12 hours after intubation and placement on the mechanical ventilation. So we don't need to wait 2 days, 3 days. So if the patient is hemodynamically stable, within 12 hours of intubation, we can use the enteral nutrition. And the energy requirement for enteral nutrition in COVID-19 is quite the same as usual, but a little bit higher. Usually we advise for patients above age of 65 years old, we use 27 kilocalorie per kg per day. For polymorbid patients per day, and for severely underweight polymorbid patients, we can use up to 30 kilocalorie per kg per day. This amount for protein is starting with minimum 1 grams of protein per kg per day, which can be increased for more than 1 gram per kg per day. So how should we prescribe this energy? Usually we give the 70% of expected energy requirement usually on day 1, and within day 3, in 3 days time, we should reach to 100% of the requirement. For the macronutrients, what should we do? Usually for the macronutrients, there have been some evidences. Zinc, vitamin D, and vitamin C is quite okay, but there is no evidence that showing that these macronutrients giving in the large doses is okay. Usually for the macronutrients prescription in ICU, the recommendation is using the RDA dose in the for these patients. So there is no need we use mega doses of vitamin C, 1,000 milligram of vitamin C IV a day, or like a 500,000 IU vitamin D a day, or every other day. Just the RDA dose of macronutrient would be okay for this patient. Of course, enteral nutrition could be impaired, could have some problem for the cause some problems for the patient. One is air leakage that compromises the effectiveness of non-invasive ventilation. Just for example, normal oxygenation with the oxygen mask, and also stomach dilatation may cause some problem with diaphragmatic function, which can cause some problem with NIV effectiveness. For the ventilated patient, as I said earlier, we have to use the enteral nutrition, and usually we see the patient with acute respiratory distress syndrome. Usually they are on the prone position, they are lying on their tummy, and usually using enteral nutrition would not cause any problem for this patient, and we can use enteral nutrition for this patient. If we have any problem, for example, the patient can't tolerate enteral nutrition, the problem with the some large air bubbles in stomach, we can use parenteral nutrition, and therefore parenteral nutrition, it has been advised we use peripheral parenteral nutrition. And the difference of peripheral parenteral nutrition with central parenteral nutrition is in osmolarity of the solution, which we have to use a osmolarity of less than 900 milli osmol. So if usually as soon as the shock is controlled and even patient is on vasopressor, on inotropes, usually we can use enteral nutrition. So don't wait until the medics they stop all the vasopressors or the inotropes. Even with the patients on inotropes and vasopressors, we can use the enteral nutrition. Even with the stable hypoxemia is a compensated or permissive hypercapnia or acidosis, we can start or continue the enteral nutrition. So as you see, we are more tolerant on the on using and continuing the enteral nutrition. One of the problems usually we have in the mechanical ventilation, after mechanical ventilation, after removing all the endotracheal tubes, is the dysphagia. So you have to make sure the patient's swallowing has been assessed. The dysphagia is not in a way that causes reduced oral intake. If the patient have the severe oral intake, the reduction in oral intake due to dysphagia, you can easily continue with the enteral nutrition. And my last slide, ECMO issues. The patient usually extracorporeal membrane oxygenation is our last option in treatment of ARDS. And usually the patients as ECMO, they have a risk of delayed gastric emptying. They have a high risk of bowel ischemia. And the one major problem, especially in parenteral nutrition, is lipid infiltration into oxygenator in ECMO, which you should have in back of your mind for these patients. So in conclusion, ICU admission is frequent in hospitalized COVID-19 patient. Malnutrition and sarcopenia is main nutritional disorders we can see in this type of patient. All hospitalized patients before or during ICU admission should nutritionally screened and monitored. And respiratory distress, prolonged hospital stay, there are the reasons that we need to have a proper nutritional intervention with oral, enteral, or parenteral nutritional support. Thank you very much.
Okay, thank you, Dr. Reza, for your clear presentation. I think it seems like there's no questions in the chat. Say
Okay.
that proteolysis and muscle degradation continues to occur, especially in critically ill patients. Are discharged from hospital, it can be around 1 year. Is there any recommendation for calorie and protein intake for this period? You said that the ONS recommended for after 1 month discharge. How
Exactly.
about the around for 1 year?
Exactly. So
Okay.
we don't have enough data for this purpose. But currently there are few studies going on protein advice and protein requirement for these patients after discharge from hospital. And usually it has been advised. I mean, it's not some sort of evidence based. Maybe it is mainly according to the experience. And but usually giving 20 grams of protein as a extra protein, maybe as a whey protein or other sorts of protein, would be appropriate for the patients up to few months after their discharge.
Okay, okay. Thank you for the answer. Because of the limited time, we are really sorry that we have to change the discussion method. The question is in the column will be sent to your email, and you can send the answer back to us later. So thank you for your time
Thank you
in
very
this
much. It
session.
was okay. It was very very good to have to participate in the meeting. Thank you very much.
Okay, thank you, Dr. Elizabeth.
Thank you, Dr. Dayan.
Okay, now we say we continue to the next speaker. The next speaker is Dr. Aman Pulungan, pediatric consultant in endocrinology from Indonesia, with the topic the Sustainable Development Goals in Children during pandemic COVID-19 in Indonesia. For Dr. Aman Pulungan, please, the time is yours, Doctor.
Okay, thank you, Dr. Dian. How is my voice?
It's clear, Doctor.
Okay. Let me share my slide. Okay. Done. Okay. Still loading. Okay. How is the slide? Okay.
Yeah, it's good, Doc. It's clear.
Okay. Assalamualaikum warahmatullahi wabarakatuh. First of all, thank you, especially for the chairing committee, inviting me for sharing. I think this is quite really wide range topic, yeah. SDG in Indonesian and children during the COVID-19 pandemic. So this is the homework for everybody, for the whole world. It's a global homework, and the question is, how could we achieve this homework during this pandemic? Because even without the pandemic, a lot of people questioning whether Indonesia could reach a lot of target for the SDG. Okay. So the SDG consists of 17 targets. You can see it here from 1 to 17, but we will talk mostly about what's related to health. Even though having said that, some other topic actually related to health, direct or indirectly, but we cannot talk everything about this. So mostly we will talk about this topic. And topic number 2, this is mostly, I think, related to the children and also for this webinar, I think. So, and all for malnutrition. And the next one is good health, well-being. The topic number 2 is SDG number 2, including for stunting. And you can see it here, stunting and wasting children under 5, but not only children. Nutrition needs adolescent girls, adolescents, and pregnant and lactating women, and also older person. Yeah, we have to remember that, not only for children. SDG point number 3. And point number 3, this is including for pandemic. Health for all, good health and well-being. And we are not ready for this. Yeah, I can say that. We are not ready for this because this is what's happening right now. If we are ready for everything, I don't think our case will be like this. So everybody, but of course, who is ready? Nobody says ready. But after 2 or 3 months, actually, we have to be ready, but not in Indonesia. During pandemic, it's still going on. So COVID-19 in Indonesia, I cannot, say everything about COVID-19 for adult, but at least I can show the data for children. For children here, that's why this is only the data. This is the real data from Indonesian Pediatric Society, from all the president of the chapter. You can see from the first cases in March right now, you can see what's the increasing of the suspect and also the confirmed cases, and also the confirmed cases of death. So we are the highest mortality due to COVID in children. First in Southeast Asia, you can say, no children die in Malaysia and Singapore, but right now we are in Asia Pacific and probably in the world, the highest mortality for children during the COVID-19. So, and what's sad thing, most of them below 5 years old. And the second one is between 10 to 18 years old. So we have the data, and also, but we are not talking. We are not talking about COVID, of course, today. But we cannot separate what we are having right now related to COVID to the homework of the SDG. If we cannot overcome this, I don't think we can overcome everything related to SDG, because with or without COVID, we are still struggling to reach this MDG or SDG target. So what is the health problem? Mostly for the under 5, mostly is the under 5 global under 5 mortality rate. And Indonesia is one of them. Our mortality, infant mortality, newborn, and also under 5 mortality is still 2-digit. And most of the country, it has to be only 1 digit, the number. Of course, first 1,000 days included here, first 1,000 days including nutrition for the adolescents and also for the pregnant women for preparing that. And we can see here, out of the country, I have the data from all the Asia Pacific country. But this is only, I can show it here from India, Myanmar, Malaysia, and Pakistan. And compared to India and Myanmar, actually our mortality and our status of the health status in children, well, we are not worse than them. We are a little bit better than them, But during the COVID, we are much worse than them. In Pakistan, I just talked 2 nights ago with one of my friends. They start, for the last 2 weeks in Lahore, there is no more cases in ICU. You can see what's happening right now in Indonesia. So this is related also to SDG. Our low birth weight is 6.2%. But there is an interesting data from the Riskesdas, from the national research data, is the SGA or the IUGR. So the baby who were born below 48 centimeters, this is also a problem. They have potential to be short, even the normal. So 10 to 15% of them, even the normal, they just do not catch up to the potential height. So they are going to be short. They are not stunting. They are normal. So this is tricky. You cannot say this is stunting because they are normal. They just do not catch up. And the problem also, the mother-children handbook, only 65%. And during the COVID, all the posyandu, the primary healthcare, they don't perform right now. Everybody busy. The primary healthcare, the puskesmas, the primary local hospital, every health person, every doctor, they busy with COVID. So how come, the mother-children handbook including nutrition of the mother, including immunization, including nutrition of the baby and the children. This is going to be a problem for the next 1, 2, or another 5 years, or maybe for another until SDG, until 2030, if we are not aware of this. Because we don't have any priority right now. What should we do during this COVID? This is the problem. There is no priority. People don't even aware there is SDG. They don't remember there is SDG that we have to overcome and to reach. So, and you can see here the first neonatal visit. For the first 24 hours, you have to measure the height, weight, and also head circumference, hepatitis B, vitamin K, and also breastfeeding. Before the COVID, it's only 37%. Let's say 38%. So what's happening during the COVID? Maybe we'll see it in 2021. And then the next one is breastfeeding, initiation. We are going to be better actually before, but this is also going to be a problem. The initial thing will be going down after this COVID-19 or during this COVID-19. So I like to remind also the data about the malnutrition, is 17.7%. This is the malnutrition, not the stunting. And the stunting is 30.8%. But this is all short children with or without malnutrition. So without nothing that we do, if we want to separate the malnutrition, the short with malnutrition, the short with normal weight, the short with the overweight, we will decrease the number of the stunting. Come on, this is the misunderstanding of the stunting. So this is the windows of opportunity if we know what to do to interpret stunting. So this is the misunderstanding of the government as also a lot of health persons. Understanding what's the real definition of the stunting. Stunting is the short below -2 SD, WHO standard, with malnutrition or without the chronic disease. So the normal short people, the normal short children are not stunting. We have to remember that. And what's happening if we don't reach the target of the SDG? Even in 2018, our Child Developmental Index is below Thailand and below Vietnam. And in some, let's say like for the learning and also for literacy, we are, some of them is below Kazakhstan. Social, emotional, we are below Kazakhstan. Nepal, we are still a little bit better than Kazakhstan. But if we are not careful, we cannot overcome this pandemic. Probably by 2030, we are below Vietnam, below Kazakhstan, below Myanmar, probably maybe below Cambodia. We don't know. We have to be careful in this. NCD in Indonesia, there is no really data NCD in Indonesia for children, but since I work for the at the RSKM, we know hemophilia problem, challenge under diagnosis, treatment and complication, thalassemia also the problem. Thalassemia is number 4 or 5 burden, for the BPJS that we have to cover it every single year actually. So oncology problem is still a burden also and challenge in pediatric and adolescents. This is the problem. We are not, we cannot utilize, and also we cannot educate them really good even during this COVID, because they should be agent of change. But we can see about the adolescents right now, higher rates of violence, accident, and suicide, and also reproductive threat. And so sad to say that. This is really sad. In Indonesia, 1 in 4 girls are married before 18 years old. You can imagine. And we get the report, a lot of divorce during this pandemic COVID. Probably this is one of them. They're just getting married before 18 years old, and then finally during the pandemic, they get divorced then. So you can see if they start having children below 18 years old, how can they can understand about SDG and the target about SDG and everything? Yeah, this is so sad. And the risky behavior, typical adolescents, tobacco use, substance abuse, drugs, alcohol consumption, and also traffic accident. And this is what we can see all over Indonesia. Small children start smoking, and they have to play soccer, they have to play football actually, but they just keep smoking. Yeah. And the school dropout also quite high in Indonesia. Diphthery, measles, and rubella, we're talking now about immunization. The target is still low. The target is still low. And what's happening? Last month, even in Jakarta, we start having diphthery cases right now, because during this pandemic, the immunization coverage will be going down. You can see here, the immunization coverage, the national, is only less than 60%. Less than 60%. So don't dream about COVID-19 immunization. Even the basic immunization, our immunization less than 60%. So you can imagine by 2021, this will be decreasing, because Posyandu, they don't perform right now. Puskesmas, primary health care, they are busy with COVID. We don't have enough PPE for them. HIV in children also a problem. Children living with HIV, estimate child health caused by HIV is quite high right now. Tuberculosis also a problem. This is part of the SDG target also. We are number 2 in the world. Number 1 is India. So India and Indonesia, we always, either number 1 or number 2 in terms of percentage in tuberculosis. Yeah, and pneumonia, we still really high. So we can imagine, if related also to COVID-19, if pneumonia, even without COVID, pneumonia still high. And the other problem, diarrhea. Yeah, I put this why, because in COVID, pneumonia and diarrhea part of the sign, the symptom. Even in adult right now, a lot of diarrhea is the first symptom of COVID-19. And we can see from the Riskesda what's the burden of diarrhea in our country. And then the child health care challenge in Indonesia. Well, this is the data from last month. Probably we have just the national evaluation, and tomorrow will be national evaluation. Probably by the end of this year, we only reach about 4,500 pediatricians all over Indonesia. And right now, last week, we just have one pediatrician die in Sumatera Utara. Not only pediatrician. Today, I heard there are 4 doctors also passed away due to COVID. So you can imagine, we don't have enough doctor, we don't have enough pediatrician, but the system cannot keep COVID from all of us. Yeah, we cannot keep our doctors safe from COVID. This is the most problem. And we can see in terms of how you can reach the pediatrician. Really easy in Jakarta, Yogyakarta, Bali, North Sulawesi, Banten, and Jawa Barat. Easy, there is the list. Difficult, Bengkulu, Lampung, South Sumatra, Jambi, and very difficult. This is really difficult, and you can imagine during the COVID, if there is, we cannot overcome this pandemic by 2021, and probably we will, we cannot overcome this pandemic by 2021, of course. And the COVID-19 pandemic impact on SDG, you can see food and security for number 2, already on the rise. Population affected from 2014 to 2019 is increasing. Stunting and wasting and children likely to be worse. There are 44 million children are stunted all over the world, and 6.9%, 40 million under 5 affected by wasting. This is the data 2019. And what's happening in 2021 after we close 2022? Only God knows if we cannot overcome this COVID. And the next one, health and life. You know, you can see need of acceleration, research decade improvement, interrupted childhood immunization program in around 70 countries, including Indonesia. Illness and death will spike. Yeah, malaria also already happening right now, and COVID-19 World Reserve years in progress reducing maternal and child death unless urgent action is taken. But in Indonesia, we are not doing urgent action. Nothing that we do urgent taken to overcome this. Yeah, we are still busy with COVID. Even with COVID, there is no urgent action. Some of the things we can say that. Yeah, sad to say this, but this is the fact. And achieve gender equality and also will be failed after this pandemic. Yeah. So we have to be really careful. This is all data. And water scarcity, you can see, we need a lot of water. Yeah, a lot of water, washing hand and everything. Probably we will fail. And water scarcity could be displaced by 2030. We know about this because also natural harm and also the problem in our nature will be affected our water system also. So before pandemic, 6% of global population predicted to live extreme poverty. Due to COVID-19, additional 71 million people could be living in extreme poverty, including Indonesia. Pandemic, worsening food and clean water crisis, rising domestic violence, political tension from COVID-19 threaten international cooperation, but also national. It could be happening. Yeah. And we need digital reform right now as soon as possible. That's what we have to do. This is from our society. We already start from Primaku, the application. You can download it. This is part of the immunization, group monitoring, and also health article, and also including here is developmental monitoring. And we have Dr. Primaku for telemedicine. So to close my presentation, I like to quote Antonia Machado from 1857. Yeah, this is what we have to do right now. He said it in Spanish, Caminante no hay camino, se hace camino el andar. Walker, there is no path. The path is made by walking. So we have to make the path right now. Otherwise, yeah, we will be lost as a nation. Yeah. Nation lost after this pandemic. So we have to be big, we have to walk, but the path is made by us. Thank you. And I hope I can explain it because this is really wide range of topic, but only for topic that, you know, I could explain it what's related to pandemic. Thank you, Dr. Dian.
Thank you, Dr. Aman. I'm really shocked here to hear and read your presentation. Yeah, we should really set about children's situation in Indonesia for
This
now
is this is
because
the this is the fact, Dr. Dian.
yeah,
Because
yeah,
even for COVID, people said, it would affect the children, but we have the highest mortality number. Come on, this is not a hoax. Come on,
yeah,
wake up.
yeah, yeah. But most people don't know. This is our homework, yeah, for our children, doctor.
Yeah.
Yeah, doctor, there's one question from Eka Wulandari. Dear Dr. Aman, I've heard that children have the highest opportunity to be a survivor at COVID-19. Then why Indonesia be the highest mortality case on the world? Is it related? Is it related to low of our children immune system?
No, 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 no. The first statement that children have the highest survival, that's the old or the previous evidence. Okay. But the next evidence, so maybe you have read, I forgot, maybe in Lancet or in Pediatric, there is a CT value, yeah? Circle threshold value. And the fact is, the evidence, the CT value for children, especially under 5, are much worse. That's related to the viral load. So this is worse compared to adult. This is the first reason. Yeah. Well, we are still writing the paper for this because every single week there is a new evidence, especially in Indonesia. The second one, of course, they are comorbid. In Jakarta, the mortality mostly because of comorbid. Yeah. Heart disease, congenital heart disease, leukemia, and also oncologic problem. But in other province, the data is from 16 to 17 province, I forgot. In other province, the comorbid are different. Stunting, malnutrition, tuberculosis, encephalitis, dengue. This is the second reason. And the third reason, they are so sad. Mostly the under 5, they just pass away because not awareness. When they come to the referral hospital, we don't have enough time to save them. They only can stay 24 hours, 36 hours, or 48 hours. Because when they come, there is not awareness of COVID, and finally when they came, so they may be, treated as diarrhea or common cold before, or asthma, or everything, or maybe dengue. And people keep doing rapid tests. This is also the problem. Don't ever do that rapid test. So they keep doing rapid tests. And finally, when they came to the referral hospital, we don't have enough time to save them. So this is the three of them. CT value is worse in children. The second one, of course, they are comorbid. All what I was mentioning before, this is all comorbid. Diarrhea, pneumonia, tuberculosis, and everything. And the third one, there is not awareness. People not aware that children can die. You know the family cluster right now in Bekasi, right?
Yeah.
There are two probabilities. The first one, the children should have it from the adult. These poor children, almost 200 or more, they may be not them. The second one, the children right now can become index cases. So wake up. Wake up. This is really dangerous. Maybe Dr. Reza also know the data on Iran, but Iran can ever come after that, They know what to do right now. And they don't have really much children die. The report in Iran, maybe Dr. Reza must know about this. So we are different. We are different. We have 34 provinces. We have 17,000 islands with inequality in testing, inequality in survival, inequality in tracing, inequality in health system. We don't live in Jakarta, everybody, Dr. Dian.
Yeah.
This is a long story,
Indonesia.
you know. I can say
Yeah.
a lot about this, you know. Yeah, I know everything about this. Every single week, we have a meeting with all the chapter presidents. So they are crying right now. They have a different culture. In Papua, different. In East Nusa Tenggara, different. In Ambon, different. Yeah.
Yeah. Okay, doctor. Thank you. Thank you very much for the interesting topic. I hope we can have a lot more time for discussion, but because of the limited time, we have to stop this session. Thank you, Dr. Aman, Dr.
Yeah, I
Eza,
hope this
for
is
your.
suitable for the topic, because mostly nutrition topic, but what I was saying, nothing.
Yeah,
Nutrition
that's
only
okay.
part of
That's
them.
okay. It's very good for us. Nice
Okay.
information for us. Thank you, Dr. Aman. Thank you, Dr.
Okay,
Eza.
thank you.
Thank you.
Okay.
Yeah, thank you,
Assalamualaikum.
Dokter. Waalaikumsalam warahmatullahi wabarakatuh.
Yeah, I
Okay,
muted now.
for
Okay.
all the parties. Yeah, thank you, Doctor. For the participants, before we start the second session, let's enjoy the following video from Fresenius Kabi. Okay. In the second session, we also have two great speakers. The first speaker is Professor Jonathan Esper, medical doctor from Hong Kong. Professor Jonathan Esper is a medical director of Fresenius Kabi. Professor Jonathan will present the topic optimizing nutrition throughout COVID-19 trajectory from admission to ICU to discharge. And the second speaker is Dr. Luciana Sutanto, physician nutrition specialist from Indonesia, with the topic how to maintain home nutrition therapy after recovery from COVID-19. Okay, for Professor Jonathan Asper, the time is yours.
Good afternoon, everyone. It's really a pleasure to be here with you today. Let me try to get my slides on. I hope you can see my slides. So once again, good afternoon. Special thanks to those of you who are frontliners caring for COVID-19 patients. Before everything else, I wish to thank Dr. Lucy and the organizers for the invitation to speak to you today. It's a great invitation. Thank you so much. It has been a great meeting so far. By way of disclosure, I am the medical director of Fresenius Kabi in Asia, but don't worry, nothing commercial today. I will only speak of scientific concepts on optimizing nutrition throughout the COVID-19 trajectory. The trajectory of COVID infection starts when the viral protein binds with the ACE2 receptor and enters into the lung alveolus.
I'm
In
sorry,
the early
Professor.
stages,
Your your screen is not available here.
sorry.
There's a share screen in the bottom of
Yeah.
your screen, the green one.
All right.
Okay.
Can you see it now?
Yeah, it's clear. Thank you.
Okay. Sorry, let me just backtrack a little bit. So I was saying the trajectory of COVID infection starts when the viral protein interacts with the ACE2 receptor and enters into the lung alveolus. In the early stages of infection, viral replication takes place, as you can see here, followed by the host response. And the host response is an inflammatory response that rapidly progresses to a hyperinflammatory state with outpouring of cytokines that is called cytokine storm. During this time of infection, we need to be able to find a way to modulate. The other thing is, if you go back to the early part of the infection in the early stage, during this time, the patient will already start complaining of some kind of GI symptoms, maybe abdominal pain, maybe accompanied by anosmia and ageusia, loss of taste and smell sensation. This will already put them at risk for malnutrition in the coming days. Therefore, upon admission, we should be aware of the risk for refeeding syndrome, focusing on the features of COVID-19 that are related to nutrition. First, the rapid progression of lung disease that will lead to respiratory failure, possibly requiring ventilation like the patient you see on the right. And planning nutrition should consider managing the requirement for oxygen, such as providing lipids rather than carbs. Resolution of hyperinflammation in cytokine storm is another important goal. Also, we need to focus on the debilitating effects of immobilization that could result in loss of muscle mass and ICU-acquired weakness. In Italy, where they experienced a very severe COVID outbreak, a pragmatic approach was taken during the emergency crisis to screen all patients and start systematic dietary supplementation upon admission with proteins, vitamins, minerals, trace elements, giving oral nutrition supplementation when possible, and when not enough, supplementing with parenteral nutrition as required. We also noted GI consequences of COVID-19 infection and that they have implications on nutrition therapy. Early in the COVID trajectory, the GI symptoms may cause poor appetite, which together with loss of taste and smell sensation will lessen oral intake and already cause malnutrition even before admission. Later in the COVID trajectory, when the patient is in ICU receiving enteral nutrition, these GI manifestations could contribute further to poor EM tolerance. In April of this year, PhilSpen, the Philippine Society for Parenteral and Enteral Nutrition, released these guidelines for nutrition therapy in COVID patients, taking into account the severity of illness, as shown on the red boxes here on the top left, and indicating, now moving a little closer, indicating at the top 3 boxes on the left. These are stages where patients are probably still able to eat with oral intake, and they should be fed accordingly. And below, high risk of refeeding syndrome, with some guidance to start nutrition slow, progress slowly, while carefully monitoring potassium, magnesium, and phosphates. The next two boxes look at hemodynamic instability and feeding in the prone position, and these are not any different from accepted practice for non-COVID cases. So whether to adapt prone positioning or not depends on whether the unit is used to handling this type of management for respiratory failure. The three boxes on the right, finally, deal with delivery of nutrition in the ICU, the later part of COVID trajectory, starting with enteral nutrition. When there is GI intolerance, then proceeding to parenteral nutrition. I will discuss this further in the next slides. The energy requirement for ward patients has been mentioned earlier. For ward patients, 25 to 30 kcals per kilo per day, whereas for ICU patients, a little bit lower, 15 to 20 kcal per kilo per day based on actual body weight. Protein requirement is 1.2 to 1.5 grams per kilo per day. The advice from recommendations uniformly is to start low-dose continuous enteral nutrition into the stomach, preferably by pump infusion, aware of the risk for nasojejunal or nasoenteric feeding access is aerosol generating and is therefore not usually recommended. Early in the COVID trajectory, the initial EN formula should be a polymeric high-protein formula. While later, when the patient is ventilated or has ARDS in ICU, it should be that is high in energy, high in fat, and low in carbs. This is to lower the respiratory quotient by burning less oxygen. And of course, containing fish oil. So the importance here is to lower respiratory quotient and consequently oxygen requirements. HCPs, of course, should be protected by providing clustered care and bundled procedures. It means whenever a healthcare professional needs to approach the patient, all the things that need to be done within that time frame should be done to minimize further approaches to the patient. We know that if target protein calorie goals are not achieved by day 3, then it's important to switch to full PN. Giving partial EN with supplemental PN does not make sense in the COVID setting because of the additional work and risk of exposure. The decision to initiate PN earlier than 3 days may also be made in case of significant GI dysfunction, problems with air leaks during positive pressure mask ventilation, a more liberal use of parenteral nutrition has been reported. Aside from the factors above, complexity of monitoring EN can also be an issue, and we need to consider ICU capacity, namely patient and procedure load. If you monitor EN closely, then it might be difficult with staffing and supply shortages, including PPEs. At any rate, PN should be administered in 3 chamber bags to minimize manipulations, providing high protein, micronutrients, and fish oil. I will explain these points in greater detail as we go along. Here, let's talk about the significance of loss of muscle mass and function in ICU. When we understand the importance of this concept, it cannot be overemphasized. The left panel shows a New England Journal study on ICU acquired weakness, showing that after just 10 days in ICU, almost 20% of muscle mass can be lost from the thigh. This magnitude of loss has been correlated with increased muscle weakness and increased infection. The middle panel demonstrates decrease in thickness of the diaphragm muscle in ICU patients, even after just 5 days on ventilator. And on the right, we see that during recovery from COVID, patients experience tremendous weakness involving not only the limb muscles, but also the muscles of swallowing. resulting in post-extubation dysphagia, possible risk of aspiration. So the loss of muscle mass in ICU is associated with ICU-acquired weakness, resulting in difficulty from weaning from ventilator support and risk of aspiration following extubation. Once we appreciate the importance of protecting muscle mass, we can then accept the importance of maintaining good protein intake. From the left in red, we can see the catabolic factors that lead to muscle wasting, including immobilization and inflammation, which are characteristic of the COVID patient. From the right in blue, we can see the anabolic factors that lead to muscle gain, or at least muscle maintenance: adequate protein, exercise, and pharmaconutrients. And of note, omega-3 fatty acids indicated by the red arrow are important not only for preserving muscle, but also for resolution of inflammation. I will explain this in greater detail. Critically ill COVID patients will definitely have increased protein requirements, maybe beyond the supply in standard nutrition formulas. In this situation, glutamine can be added both to EN or PN to increase the amino acid intake. IV glutamine in PN can also complete the amino acid profile of standard parenteral nutrition, which is an important step, along with additional clinical benefits of stronger gut immunity and heightened insulin sensitivity. 2 slides back, I showed you that omega-3 fatty acids could be important in preserving muscle mass. This slide shows recent studies that explore the concept further and elucidate the mechanisms by which omega-3 fatty acids have an anabolic effect, namely activation of mTOR signaling, reduction of insulin resistance, resolution of inflammation, and antioxidant defense. It is encouraging to know these probable mechanisms because this is a relatively new concept for omega-3 fatty acids. What is more commonly known about fish oil is related to modulation of inflammation, and this is very important in COVID-19 because of the hyperinflammatory nature of cytokine storm, which almost inevitably puts the patient at risk for multiple organ dysfunction, leading subsequently to multiple organ failure. Inflammation is usually a physiologic process, but when it becomes exaggerated, it can lead to overwhelming inflammation, leading to organ failure, or it can lead to immune paralysis, leading to breakdown of host defense, as you can see here. The importance of omega-3 fatty acids is to modulate the exaggerated inflammatory response and bring them closer to the physiologic range, where it can become beneficial. In fact, this action is attributed to specialized pro-resolving mediators, or SPMs, derived from EPA and DHA, the resolvins, protectins, and maresins, that bring about resolution of inflammation. This has also been demonstrated in viral infections, as shown on the right. In fact, the importance of fish oil in modulating inflammation is highlighted in this slide. On the left is a study from Brazil, which has been really hard hit by the COVID pandemic, suggesting that parenteral fish oil could be an adjuvant pharmacotherapy for COVID-19. And on the right, you can see further elucidation of the therapeutic value of fish oil as an agent that brings about resolution of inflammation by the pro-resolving mediators, specifically in COVID disease, where you need resolution-based therapies. I apologize that this is a busy slide. Just focus on the important concepts in bold blue fonts. On the left is the latest meta-analysis from late last year that looked at the use of IV fish oil lipid emulsion as part of parenteral nutrition in 49 randomized trials with over 3,000 500 patients. The study showed benefits of 40% reduction in infection risk, 56% reduction in risk of sepsis, as well as shortened hospital length of stay and ICU length of stay. On the right is an analysis of ARDS patients showing the benefits of fish oil supplemented enteral nutrition this time, namely improved 28-day mortality, shortened duration of mechanical ventilation, and consequently shorter ICU stay. There have been concerns about the risk for bleeding with the use of fish oil. It has been clearly shown in several studies, and here you see the most recent one, confirming safety of omega-3 fatty acids in the therapeutic dose of 1.5 grams per day for up to 1 year, or even for higher doses up to 10 grams per day for short-term use. There is clearly no evidence for risk of bleeding with the therapeutic doses of fish oil that are used in nutrition. Now we come to the topic of micronutrients, and I know you're interested to hear about mega doses of vitamins. This is another busy slide. What you see on the left are the micronutrients listed in blue, and please pay attention to the screen now. You will see some red boxes appear indicating the point in metabolism where they participate in the energy substrate metabolism, including Krebs cycle at the bottom of the screen, which all take place in the mitochondria. There is no evidence for benefit of megadoses of single micronutrients. Repeat, not enough evidence. And therefore, all of the micronutrients should be provided on a regular basis for all patients receiving exclusive or full PN. What about testing? Rather than spend money on cost of testing for blood levels, it is better to just provide micronutrients regularly as part of parenteral nutrition. Here you see a more simplified view of the previous slide, showing the different vitamins, minerals, and trace elements in the red box, and indicating in the left in blue which clinical setting they exert their actions of antioxidant and immune defense, as well as their role in energy and substrate metabolism. Finally, we come to my closing slide. In the past 18 minutes or so, I have tried to emphasize the importance of nutrition screening and assessment for COVID patients throughout the entire trajectory of their illness, and whenever indicated, to start nutrition slowly, mindful of the risk for refeeding syndrome. Oral supplementation can be sufficient for mild cases early in the trajectory, but for moderate and severe disease, especially in ICU patients, enteral nutrition should be preferred, with, however, a lower threshold to initiate PN for certain circumstances. What are they? Could be very severe illness and malnutrition, poor EN tolerance, issues with mask ventilation where positive pressure by mask can cause air leaks or gastric distension, and more important, limited ICU capacity and expertise for monitoring EN. Fish oil supplementation is an important part of both EN and PN, and as well, micronutrients, vitamins, minerals, trace elements for patients receiving parenteral nutrition. Finally, when the patient is discharged from ICU extubated, watch out for post-extubation dysphagia because of the high risk for aspiration. You may have saved the patient in ICU only to lose the patient from aspiration after discharge from ICU. In addition, remember these patients have been in ICU, they will be fatigued from all the tubes that they have had. They will be reluctant to have another feeding tube inserted. Here, nutrition can be continued with simple peripheral parenteral nutrition until discharge at the end of the COVID trajectory. And here, at this point, nutrition education should be provided to promote a timely recovery. I have come to the end of the presentation. Once again, I thank the organizers for the invitation. Dr. Lucy, thank you. I thank the audience for your interest and attention, and I look forward to answering your questions in the Q&A. Thank you.
Okay, thank you, Professor Jonathan, for your clear yet easy presentation. It's so interesting. We continue to the next speaker. The next speaker is Dr. Luciana Sutanto. This is your nutrition specialist. Dr. Lucy, the time is yours.
Good afternoon, dear professor, colleagues, and friends. Thank you for joining the session. Thank you to moderator, Dr. Dian, for introducing me. Can you hear me clearly?
Yes, doctor. Clearly, doctor.
Thank
Loud
you.
and clear.
Thank you, Dr. Pitara. Also, thanks to the committee and to President Kapi for inviting me to share about how to maintain home nutrition therapy after recovery from COVID-19. I will share. Hope you can see my slides clear very well.
Yes, very good, Dr. Lucy. You can continue.
Back home, as a COVID-19 survivor, it's a grateful and happy time. How many patients are recovered? I took two data from 6 September and the other is 10 September 2020. We have here, these slides show the number of recovered patients. There are more than 70% patients survive. Patients who has recovered have different conditions. Here we have quite healthy, here reasonable healthy, but here weak. When this patient needs a home care treatment. In this afternoon, I will focus on this condition and this condition, the healthy and the reasonable healthy. Recovery patients have different condition history, from mild, moderate, severe, and critical. Here we can see that COVID patient in ICU, they stay longer than ordinary pneumonia cases, up to 2 to 3 weeks, and give impact to severe weight loss. When patients in pulmonary rehabilitation condition, they need very good nutritional support, apart from another important treatment like breathing management, exercise training and maintenance, diagnosis and management of comorbidities, action plan, baseline and outcome assessment, maintenance strategy, self-management, optimization of pharmacotherapy and oxygen administration, interdisciplinary education, and energy conservation. Professor Wismeyer, when he was treated in ICU, he published a journal about his sickness. He lost lean body mass over 20 days following surgery and critical illness, 20 kilograms over 20 days, means equal with 1 kilograms lean body mass loss per day. This is what patient in ICU And complication associated with loss of muscle. Here we see loss of lean body mass 10%, associated complication, decreased immunity, increased risk of infection, decreased wound healing, increased muscle weakness, increased risk of infection when the patient loss of lean body mass around 20%. 30%, the complication are difficulty sitting, pressure ulcers, pneumonia, inability to heal, and 40% increased risk of death. What the patient have done in when recovering from COVID-19 at home? Here, in this opportunity, I will not talk all about this. I will focus in good nutrition. Good nutrition, quality sleep, recommended to sleep 7 to 9 hours a day because sleeping also stimulate the immunological in the body. Physical activity and sport to stimulate the synthesis of protein, and stress management. ASPEN and another professional organization publish a recommendation about what to eat at home after being in the hospital with COVID-19. You can download this brochure free from the website. The recommendation said, eat foods with protein at each meal. Try to have whole grain bread, pastas, rice, or cereal at each meal. This is a complex carbohydrate. Keep track of what you are eating, the patient eating, and drink 8 to 10 cups of fluid per day. 8 to 10 cups included milk, soup, and soft drink, and others. If patient got problem in poor appetite, fatigue, or feeling full quickly, what do they have to do? Eat small frequent meals 4 to 8 times per day, or eat every couple of hours. Eat foods high in protein first at meal times. Eat high calorie and protein foods. Add gravies and sauces to meat, poultry, and side dishes. Drink milkshake or meal replacement protein drinks between meals. Consider a multivitamin supplement if cannot eating enough or less than 50%. If they got problem with taste changes, what they have to do? Eat foods they are bland to start and then add flavor. Try colder foods to start because hot foods can have a strong taste. Add sugar, salt, seasonings to flavor food. Use sour candies, mints or gums before and after meals if the mouth is feeling dry. Brush teeth regularly. If the patient got a swallowing problem, have to consult with the doctor. Practical approach to provide protein and calories using the phases of critical illness and convalescence. Here, the recommendation is very good, but this this opportunity, I just want to focus on post-hospital discharge, rehabilitation status of patient. They need 35 kilocalories per kilogram per day, per kilograms body weight per day for calories, or 150% of indirect calorimetry measurement. And protein increased to 2 to 2.5 grams of protein per kilograms per body weight. And consider prolonged enteral nutrition, oral nutrition supplements, or protein supplements. And patient at risk for prolonged reduced calorie intake, consider the use of oral nutrition supplements, ONS. Patients are at risk for prolonged reduced protein intake, consider the use of oral nutrition supplements, ONS again. Don't forget to monitor Monitor oral intake and oral nutritional supplement intake. Consider functional muscle tests and follow-up of body composition. Don't forget to monitor the patient. Oral nutritional supplements, ONS. The British Association for Parenteral and Enteral Nutrition define ONS are sterile liquids, semi-solid or powders, which provide macro and micronutrients. There are many types of ONS. Juice types have volume range from 200 to 220 millis with energy density 1.25 to 1.5 kilocalories per milli. They are fat-free. Milkshake type 125 to 220 millis. Energy density range from 1 to 2.4 kilocalories per milli. High energy powders 125 to 330 millis with energy density 1.5 to 2.5 kilocalories per milli. Soup type, volume range from 200 to 330 millis, energy density 1 to 1.5 kilocalories per milli. We still have some, many solid or dysphagia range. The energy density 1.4 to 2.5 kilocalories per milli, high protein containing 11 to 20 grams of protein and volume ranging from 30 to 220 millis. Low volume, high concentration, we call it short, typically 30 to 40 millis as a dose taken 3 to 4 times daily. ONS should not be prescribed without being monitored to ensure that they remain appropriate and are being taken as prescribed. Stop when dietary intake is meeting nutritional requirement, weight has increased to target, BMI is within healthy range, the individual medical condition has changed. For example, the individual with the swallowing difficulty recovers, the individual can no longer tolerate them due to taste fatigue. Identify and treat patient with malnutrition. Ask patient to write down how they can eat. If they have eaten none, 0%, or if they can eat all 100%. We can use this model to explain how much patient can eat, like 25%, 50, 75%. This is the example of oral food and oral nutritional supplements. Oral food, some patients it's not very easy to eat traditional or common food, but we can suggest them to eat like porridge or soft food like this, and with the or mix with the oral nutrition supplements. We can make the meal plan like this. If patient quite weak, so patient drinks oral nutritional supplements for every schedule. They will got total calories 1200 to 1800. Or if patient quite can eat meal, so we can suggest to change the ONS with meals. So patient can get up to 1800 calories. And when patient can eat usual meal, then the ONS only for extra for the patient, and the patient still can get 100. This, all patients who come out of the hospital after COVID must see or speak to a nutrition or diet consultant and the physiotherapist in the first week. Be careful with malnutrition. INA is the supporting sponsor for Malnutrition Awareness Week. And if you are interested in get complimentary access to the educational webinar and resource, please visit in our website. Thank you.
Okay. Thank you, Dr. Lassi, for your clear presentation. It's very nice. So we continue to the discussion time. There is 3 questions for Professor Jonathan. Hello, you still there, Professor Jonathan?
Yes, I was
Yes.
Thank him.
Yeah. For Professor Jonathan, there is 2 questions. I will read one by one. From Husna Asri, dear Professor Jonathan, is it necessary for a healthy person to take supplementation for the certain important micronutrients during COVID-19, such as fish oil, vitamin C, or vitamin D, for nutrient deficiency prevention? As I see, there's slightly increase in buyers for these types of supplementation, as they claim good for COVID-19 prevention. Please, Professor.
Yes, I think we need to distinguish. When you say healthy individuals, we need to distinguish on one hand, healthy but low risk or healthy but high risk.
Yes.
So high risk means our elderly people. Yeah, elderly with comorbidities, etc. In that situation, there is a clear yes to build immunity and immune response by taking daily supplementation of vitamins. Fish oil can be included as well. In younger, healthy individuals, this need is not so great. So we need to make that kind of distinction. If finances are not a problem, then by all means, everyone should strengthen the immune system. But we know if you take 1, 2, 3, 4, 5 grams of vitamin C, but you're in a party without a mask, or you're
All
joining
same.
protest in the street, it doesn't protect you.
Yeah.
It doesn't work that way.
Okay. Dr. Lucy, do you have some opinion for this question?
I agree with Professor Jonathan. We have to
Okay.
wear masks. Then
Okay.
we have to eat healthy food.
Yeah.
Tell
Please
me.
note we include ourselves among the young and healthy.
Okay. Okay. The next question is from Dewi S. Febri. Dear Professor Jonathan, I want to know about vitamin C for COVID patient with ARDS or acute respiratory distress syndrome. Is it recommended to give high dose of vitamin C? How much dose of vitamin C can we give safely to these patients?
I will answer second question first. How much can you give safely? In the absence of renal failure, there's no limit. Any excess of vitamin is excreted in the urine, and if you have normally functioning kidneys, it doesn't matter. So we come to the more important question: does it make sense? There is no evidence that's strong enough to conclude that mega doses of vitamin C have any benefit. I hope I made the point clear that rather than give mega doses of individual micronutrients, it's better to give a, how do you put it, a complete range of vitamins, minerals, and trace elements. There's another aspect that we need to consider. When we talk about individuals outside the hospital and talk about vitamin C deficiency because of lack of intake of sources of vitamin C like vegetables, fruits with citrus fruits, etc. That's different. That's a deficiency. In hospital patients, in critically ill patients, the reason for low levels might be redistribution within the body compartments. So that's a different aspect to consider. But having said that, it makes sense to provide only up, I would say only up to 1 gram, certainly not more than 2 grams per day. But again, my personal preference would be to give a multivitamin, multimineral trace element preparation, especially in parenteral nutrition patients, because PN solutions don't include this. And otherwise, we need to go by evidence. I hope that clarifies.
Okay, thank you. It's clear and I agree. How about you, Dr. Lucy? Do you agree?
But he's my favorite speakers.
I agree with you. Yeah, the next question from Dr. Aris Rivaldi Wicaksono. Thank you for the presentation. I would like to ask to Prof. Jonathan Esper and Dr. Luciana, is there any benefits on giving protein food source only from sea fish rather than the other protein resource as the daily menu in patient of COVID-19, especially in ward unit? Or we just need to maximize oral nutrition supplement which has calculated protein and omega-3 fatty acid. Thank you. Please,
Professor?
Professor.
Uh, the choice of protein doesn't really matter. What you need to calculate is the protein requirement fulfillment, and it is between 1.2 to 2 grams per day. In very critically ill patients, it can go, or very catabolic patients, it can go up to 2 grams per day, but this is very difficult to deliver. Whether you get the protein source from fish or meat or plant-based protein, in this case, doesn't really matter so much. And if you're able to fulfill your protein requirements by oral intake early in the trajectory of COVID-19, then it's fine. If you're in critical illness, then you need to receive it from enteral nutrition. ONS is not enough. Maybe you need enteral nutrition or parenteral nutrition, then that's fine. You just need to make sure that the solutions you are receiving are providing enough protein. And you just calculate grams of protein in the formula and patient's body weight, actual body weight. I mentioned earlier, in case some solutions do not provide enough protein, particularly in very critically ill patients, then you can supplement with glutamine. And the important part about glutamine is making the, especially in PN, making the parenteral nutrition have a complete amino acid profile, because the completeness of the amino acid profile makes the optimal situation for protein synthesis, building up muscle.
Okay, Dr. Lucy, please
I
your
agree,
answer.
yes, I agree with Professor Jonathan. I just want to add about the patient at home to protect from COVID. They always think that eating many things or fancy things will protect from the COVID infection. But actually, that's not true, because we have to protect with sanitizing ourselves, washing hands, wearing masks, and don't gathering and don't go to the things that is not important, and eat properly healthy food with enough calories and proteins and other nutrients. And protein, about protein, I agree with Professor Jonathan that that a protein from fish is good, but protein from another source is also good. So every food will complete each other, because there's no what we call it perfect food in the world. They always have good in this thing and lack in another thing. So they will complete each other. That's what I think about protein.
Yes.
Protein needs.
Actually, I'm surprised the question was about fish. I would have expected the question to be about plant-based protein, because in the past we used to say egg is the best source of high biological value protein. Today we know that vegetables provide also high biological value protein. So plant-based, even plant-based protein is just as good as meat or fish.
Because very popular in Indonesia, a kind of fish who can giving a good source for the health.
Yes, there's also that similar belief among the Chinese. From the scientific point of view, they're all the same: meat,
Yeah,
fish, or plant-based.
yeah. It's very interesting if we talk about the protein. We still have 5 more minutes. We continue to the next question from anonymous attendee. Dear Dr. Luciana, if the patients already have the energy intake exceeding 1,800 kilocalories per day from their meals, does the ONS still needed for them?
This question I will answer, but Professor Asper also can answer better than my answer. I know.
You cheat. It's for you.
I will answer this. ONS is not necessary if we can eat complete food, what we need. But sometimes I only drink ONS when I go somewhere that I think that I have no plan. I have no time to have lunch, so I bring this. I'm very busy. But ONS is very useful if the patient is quite weak to eat common or traditional food.
Yeah, I
Okay.
agree, Lucy. Just one thing to add. The emphasis here in the question was calories. In today's world, the community of nutrition looks more at protein than calories. So let's have a paradigm shift from counting calories to looking at protein first. And often it might be that some formulations might provide adequate calories but not enough protein.
Yeah.
And we need to emphasize protein is more important at this point in time than calories. If you have, if you exceed delivery of protein, the mortality risk will continue to go down, even if you increase protein intake in the absence of liver and renal failure. But if you exceed calories, too low, too much, or too
Yeah.
little calories can be harmful. But with protein, increase protein, no harm. More survival benefit.
Okay. Thank you. I think we have one last question. Uh, Good afternoon, everyone. Allow me to introduce myself. My name is Diki Prasetya, medical student from Krida Wacana Christian University, Jakarta. I think this is a Dr. Lucy student.
Yeah.
When patients are showing indications for ONS, example, Gracia, taste fatigue, does it mean we have to switch to another type of ONS or go straight to regular normal meal? Thank you.
Actually, I don't really clear the question.
Okay.
If patient very weak or
When the patients are showing indications for ONS, example for taste fatigue, does it mean we have to switch to another type of ONS or go straight to the regular normal meal? Yeah, it's kind of confusing question, isn't it? I think.
I will try to answer this question. If patient can eat, so please eat. Ask the patient to eat.
Yeah.
If patient cannot eat, ONS is one option to fulfill the requirement nutrient for patient.
Yeah, fully agree. If patients are or if individuals are eating well, there's no need for ONS. If they cannot fulfill their energy and protein requirements by their meals, this is where ONS comes in. The other part of the question was taste fatigue. This is why some products are made with different types of flavors, and some manufacturers are making flavors that cater more to Asian taste than Western taste. So yes, sometimes taste fatigue can be a factor. If there is an indication for ONS and there is taste fatigue, then you look for another substitute product that has a different flavor.
Okay.
And also we have to if we have to pay attention with the obesity, because maybe patient don't feel still wants to be healthy, but think about the obesity.
Okay. Yeah, this is a very nice discussion, very interesting, but we were sorry for the limited time we have, so I have to end the discussion, the sessions. The rest of the questions we will email to your email, Prof. Jonathan, if you don't mind, so you can answer it by email and send us back the answer. Thank you, Professor Jonathan. Thank you, Dr. Luciana, for your time in the sessions. I hope we can meet with the real symposium next year if the pandemic is over. We hope so. Thank you. Thank you very much.
Thank
Thank
you.
you, Lucy.
Bye-bye. Okay, now let's enter in the last session for today's sessions. We will have 3 speakers. The first speaker is Professor Marek Nauwels, PhD, medical doctor from Australia. Prof. Marek Nauwels will present the topic about COVID-US, a simplified cardiopulmonary ultrasound approach to use in suspected and confirmed COVID-19. The second speaker is Professor Dr. Arif Fahri Alsham from gastrointernist consultant in gastroenterology and hepatology from Gastroenterology and Hepatology Division, Internal Medicine Department of Faculty of Medicine in Universitas Indonesia, with the topic COVID-19 treatment during and after recovery, what to expect. And the last speaker is Dr. Jualita Surapsari, physician nutrition specialist from Indonesia, with the topic, what shall we do to boost the immune system of people diagnosed as asymptomatic COVID-19? For Professor Marek Nauwels, the time is yours.
Thank you, everybody, and thank you for allowing me to speak at your online webinar at the Indonesian Nutrition Association. So I'll talk a little bit outside of nutrition topic, but still concerning the COVID-19. And I will share the screen and I'll share with you some knowledge about ultrasound use during COVID-19. Can you all see my screen?
Yeah, it's clear, doctor.
Okay, very good. So as you know, we're dealing with the severe acute respiratory syndrome coronavirus. That's a new RNA coronavirus and presents as a flu. And typically, coronaviruses cause respiratory and enteric infections. And some patients present with severe interstitial pneumonia, acute respiratory distress syndrome, and multi-organ dysfunction of heart, vessels, liver, kidney, and other organs. And we can use ultrasound to investigate these. What is actually the burden of COVID-19? We know that most people are actually asymptomatic. That's more than half the infected people. And even from the symptomatic, only about 10% of patients present with severe interstitial pneumonia. The problem is that the attack rate is very, very high. And so we are dealing with a large number of patients. Most patients who develop severe disease have coexisting medical conditions such as hypertension, diabetes, obesity, and cardiovascular disorders. And we know that mostly elderly and frail patients or those with underlying severe disease do die. To put some numbers to it, you can see on this graph from the Office of National Statistics of England and Wales that there's some excess numbers of death for about 7 to 8 weeks, and they range from 3 to about 15,000 excess death in a week. So that's a substantial number of dead people. How can we diagnose COVID-19? We know that all of us had a nasopharyngeal swab. I'm pretty sure I had 2, luckily negative. They have high specificity, although you can get false positive results due to swab contamination. And they have about moderate sensitivity, which is mainly due to ineffective sampling because we need cells present in the sample in order to be able to run the RNA testing. the PCR. Now, patients who present to hospital often have dyspnea, tachypnea, and they are severely hypoxemic. However, often they don't look like that, and we call it silent or happy hypoxia. These people talk on the phone while having saturations in their 70s or 80s. But that respiratory failure is actually the commonest reason for hospital admission. Out of those people who are admitted to hospital, about 10 to 20% come to ICU. About 3 to 10% need intubation and ventilation, and unfortunately 2 to 5% of people die. So how can we assess the lung in COVID-19 disease? We can measure the oxygen saturation, as we all do. We can do x-rays, we can auscultate, but with auscultation there comes potential for contamination. We can do CT scans, and that's complicated as well, as we'll mention, or we can use ultrasound. So what is the role of lung ultrasound? Lung ultrasound can be diagnostic in COVID-19 disease, even in patients who don't have positive or don't have a PCR test done at all. Because although it's not very specific, you can have findings similar in other pneumonias or pneumonitis. It is quite a sensitive, even higher sensitivity than the PCR test. If the patient has known risk factors, has been in contact with COVID disease, and has those changes, then the diagnosis can be made. And lung ultrasound is also prognostic because it predicts the need for invasive ventilation and also can predict mortality. And it can help us in a pandemic situation to plan disposition of patient and effective resource allocation, therefore not sending patients who don't need to ICU to go to ICU. Patients who can be discharged because their lung ultrasound is normal can go home. So CT scan, let's talk about that. We all know that we see a lot of different changes depending on how the disease progresses. We initially see some ground glass shadowing, then some opacities, some consolidation, especially subpleural, and some focal consolidation. And it all progresses, and within weeks, in patients who are going to die, we see quite dense consolidation and or what's called honeycombing, fibrosis of the lung. But CT scans are costly. There's difficult logistic taking patients who are sick, hypoxic, or mechanical ventilation, and who may be potentially infectious through the CT scan. That then requires cleaning, takes a lot of time, and there's also the radiation exposure. And it's also not necessary for most patients because it doesn't really change the management in most. And so we use CT scan for those who really have unclear clinical picture, where the differential diagnosis is unclear, or if there are unexpected complications. But lung ultrasound in contrast is practical. It is a bedside point of care test. It's dynamic and it's repeatable. And this is an example of a normal lung ultrasound where we see some lung sliding, what we call pleural sliding of the visceral and parietal pleura, and some A lines. We can see that in COVID-19 pneumonia, from A line, which is the normal picture, we go to see B lines, and B line can be one or multiple B lines, or the disease progresses or is severe enough at the start, we see consolidation. As the disease progresses, we can then call it interstitial syndrome with multiple B lines. We can look at the pleural line, which is, unlike other viral pneumonias, quite irregular and thickened, and frequently patients develop subpleural consolidation and reduce lung sliding at that spot. So here we see the dynamic, actual live B lines, multiple B lines in this patient who's got pneumonia in the anterior part of the chest. We can see here that there is a missing part of the pleural line up here, and you can see that that's typical of the subpleural consolidation in a patient with COVID-19. And as we go to the base of the lung, again, multiple B lines are significant for what's called interstitial alveolar syndrome in COVID-19 patients. And as the disease progresses, or again, as if the severity is high, we can see basal consolidation, sometimes small pleural effusion, although they're not very frequent, and again, multiple B lines. And then very dense consolidation towards the end stage of disease, or in very, very severe disease where the patient has got significant hypoxemia and needs mechanical ventilation that is often ineffective. Well, there's been study, this study is from Israel, where lung ultrasound has been used to predict clinical course and outcomes in COVID-19 patients. And they clearly shown that abnormal lung ultrasound on hospital admission not only predicts survival, but also the need for mechanical ventilation. We can look at complications. Sometimes patients who needed mechanical ventilation, especially if they have underlying COPD, can develop pneumothorax. And again, we can check that with lung ultrasound where pleural sliding is absent in the condition of pneumothorax. So to summarize, lung ultrasound COVID-19 disease is used for risk stratification, for prediction of the patient's course. It can guide the triage and resource allocations for COVID-19 patients, and it can determine the management strategies. So what about the heart cardiovascular ultrasound? There's of course heart troubles in COVID-19, and we don't know much about those and the long-term consequences, but what we do know is patients who have chronic cardiovascular conditions have higher likelihood of infection, so they are more likely to get sick. They also develop more severe disease, and they have a greater risk for dying. And patients who develop severe COVID-19 disease, and perhaps not surprisingly because they chronically have cardiovascular problems, 44% of them have arrhythmia and about 58% have hypertension. Cardiac infections with COVID-19 also develops, and that can lead to myocarditis and pericarditis. And it's seen in up to about 12% of patients, and usually it's accompanied by elevated troponin. So if you have elevation of troponin in your COVID-19 patient, think about myocarditis. However, because of the inflammatory response, hypoxia and thrombotic state, and other traditional risk factors like immobility and being on mechanical ventilator, having medication administered, patients develop cardiac arrhythmias de novo. They can develop pulmonary embolism, especially microemboli and microthrombosis in the pulmonary vasculature. And in fact, all the patients that we have looked after here were fully anticoagulated with enoxaparin for that particular reason. And also type 1 and type 2 myocardial infarctions can develop in COVID-19 patients. As we said, a lot of them have chronic underlying conditions like chronic heart failure, and some of them will have valvular heart disease that is common in elderly people, common in patients with hypertension. Not to forget, some therapies that were used and some that are used for COVID-19 can also have adverse cardiac consequences. So a lot of patients are on medications such as azithromycin at prolonged QT interval. Some are on hydroxychloroquine or antiviral medication that can also either prolong QT or have adverse cardiac events. So this is an overview from a nice paper from the American Journal of Emergency Medicine, where it summarizes what the risk factors for heart disease in COVID-19 patients are and what are the expected complications, what we need to look for. And we can utilize ultrasound to do that. So we can look at a 4-chamber view at this patient who's had COVID-19, and we can see that his heart is normal. Apart from the tachycardia, this patient's heart is not too bad. But there are some other patients who develop left ventricular dysfunction, and we can again see that, and you can see the difference. And there are patients who develop right ventricular dysfunction, especially those ones on mechanical ventilation who require a significant amount of positive airway pressure. They right heart then is under large strain, and typically patients have at least mild but more often a moderate pulmonary hypertension, as the vasculature also gets affected by the microthrombi and the pulmonary parenchyma by ongoing fibrotic changes. Sometimes we need to distinguish whether the problem is on the left side of the heart or the right side of the heart, whether it's caused by the lung or whether it is caused by hypertensive heart disease in the background and diastolic heart failure, or if it's caused by pulmonary hypertension and right heart failure. Again, we can use sophisticated methods in ultrasound, such as Doppler, color Doppler, continuous and pulse phase Doppler, along with the lung ultrasound to distinguish one from the other. So, in conclusions, combining the powerful diagnostic tool of bedside lung ultrasound with echo allows rapidly to assess cardiovascular and respiratory status of patients with COVID-19. It allows to dispose of the patient in an appropriate way, either send them home if they don't have any problems with their heart or lungs, or put them into normal ward, COVID-19 ward, respiratory ward, or they will need ICU admission. It is mandatory to wear appropriate personal protective equipment if you're going to do an ultrasound. Use dedicated machine if you can. That's dedicated only to scan COVID-19 patients or suspected patients. Make sure the machine is fully decontaminated after use, same as the probe. If you have the ability, please cover the machine and the probe with a plastic sheet, and be meticulous not to spread the disease amongst patients and not to infect yourself or your colleagues. So don't forget to wear appropriate personal protective equipment. And I'd like to thank a few people towards the end of my presentation. One is Iris Ting, who taught me all about cardiac echo, Professor Daniel Lichtenstein, who taught me a lot about lung ultrasound, and of course, Dr. Lucy Sutanto, who invited me to speak at INA, and Professor Xavier Leveve, who introduced me to Dr. Sutanto. Thank you very much, and it was my pleasure to be able to give you this talk from my home in Australia. Thank you.
Okay, thank you, Professor Narek, for your interesting presentations. I think there's a lot of new information for us here. Now we continue for the next speaker. The next speaker is Professor Dr. Ari Fahri-Alsyam, internist consultant in gastroenterology and hepatology from Indonesia. To Professor Ari, the time is yours.
Okay. Thank you. Yes. Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. First of all, I would like to say thank you to organizing committee to invite me to talk in the important conference with on virtual meeting. Yes, I think Professor Marek have give us about the how we make diagnosis of the COVID-19, and right now we'll talk about the treatment. I mean, the some treatment, you know, the progress of the treatment for COVID-19 patient. The outline of my talk, and yeah, before we start, or before we talk about the, before we discuss about the treatment, I will show you about our last data from website of WHO. Right now, the globally numbers of confirmed patients 28 million, and then around 900,000 deaths reported from WHO. How about the Indonesian case? So we can see just today confirmed case 210,000, and we know that there are around 2,000 still in hospitalization, and then but we know that around 70.2% our Indonesian patients healed, but around 4.1% deaths. So the problem is that right now the numbers of the case, confirmed case, increase term by term. This is our problem here in Indonesia. Okay, the treatment. So we know that we have what we call the basic pillars of outbreak response network. So yes, I think we must we are in the evidence-based public health environment and encourage local ownership of the outbreak control response measure. Hope so. This discourage the politicizations of the COVID-19 response. You know that sometimes the response is counterproductive for the community, and leverage in country expertise of experience of big responders, invest the rapid expansion of the public health workforce, and make decisions of the basis of comprehensive strategy, the latest evidence, and also the epidemiologic situation. So I think government need expert to help them to evaluate about the last situation, and then they must get information from clinicians, epidemiologists, or to give when they will make decisions, and also ensure equitable access to diagnosis tests, therapeutic, and vaccine. So yes, you know that the clinical trial on vaccine still going on, and also some clinical trial is still going on, and champion multilateral action and international solidarity. I think we know that this pandemic have increased the solidarity for everybody. Yes, I tried to look for PubMed about to know that the clinical trials, and I use the keyword COVID-19. Yes, around 106 results mention about the result of the clinical trials. This is one of the clinical trial, the positive thing, the positive one, about the using of glucocorticoid with or without tocilizumab versus supportive care only. You know that the can develop to be suffer with cytokine storm syndrome. So for this situation, we need to give the anti-inflammations such as glucocorticoid and also tocilizumab. From this research, we can see that the effective using of this treatment compare with the placebo group. Okay. Yes, I tried to look for the clinical trial that using nutrition. So I got one of the 5 ingredient nutritional supplement and home-based resistant exercise improve lean mass and strength in free living elderly. From nutrients, from this research, from clinical trials, you can see that from body fat, and also from ASM, you can see that the supplement can improve these conditions. And the conclusion of this research mentioned that this supplement is a safe, well-tolerated, and effective complement to low intensity and home-based resistant exercise, and improves lean mass, strength, and overall muscle quality in old age. I think there is some information or some evidence that most of our COVID-19 patients' loss of body weight. Okay, you know that the first time that the pandemic come, yeah, we are surprised that one of the medicine that we can use is a chloroquine. You know, this is the picture of that how the virus attached to receptor, and then this picture show that how that chloroquine can prevent replications of the virus into the cells. But however, uh, there is no difference in 28-day mortality hydrochloroquine compared with the standard care. So that's why in the solidarity trial, we cannot use the chloroquine to continue the clinical trials. But right now, some university will make collaboration to use chloroquine as a prevention. Yeah, and University of Indonesia, and also with Mahidol University and Oxford to prepare the study of the preventions using chloroquine for health, especially for health worker. Yes, this is another medicine that also, yeah, we hope that this medicine will work. But from this study published in Lancet, mentioned that the remdesivir use was not associated with the difference in time to clinical improvement. But the using of remdesivir is still going on on solidarity trial, also here in Indonesia. I know that some hospital participate in this clinical trial using remdesivir. Yes, how about the pepviravir? Remember, if you remember that, yeah, in the middle of March, that our president mentioned that our Republic of Indonesia government have ordered Afigan. Afigan is pepviravir, and also chloroquine at the time. But until now, we are still waiting the result of the pepviravir. And also, we have a clinical trial of this medicine in University of Indonesia. There is some hospital participate in this research that we have submitted in clinicaltrial.gov. And you know that until now, there is around 66 studies registered on clinicaltrial.gov. 7 completed, 15 regretting and not regretting, and then 1 withdrawal. Because in the study, they compare using the chloroquine, compare using with the pepviravir. This is another medicine that also we hope that it works, especially for patients with severe COVID-19. You know that hope so that the passive antibody-based immunity can reduce duration and or disease severity in patients with suboptimal immunity. Hope so that, and convalescent plasma is obtained from individuals who have recovered from infections and have generated an immune response, probably ones with high titer. This is a procedure that they must have a high titer of antibody from them. So we can use this for the study. Yes, how about the dexamethasone? Yeah, I think this is the primary report from recovery trial, dexamethasone reduced the number of mortality rate in see these pictures, you must be careful because this drug only effective for patients with invasive mechanical ventilations and also with the oxygen only, and then not effective for no oxygen received. So you must be careful. But if you remember our people, Indonesian people, have they read from newspaper that dexamethasone can work for COVID-19, they use as a prevention medicine. So it is not true, and then so we must. This is that we need to explain if there is a research from abroad or from publication to make what is the importance of medicine. Yeah, something like this, the dexamethasone only for patients with invasive mechanical ventilations. This is another medicine that we are also on clinical trial in Faculty of Medicine in Indonesia and also Cipto Kusumo Hospital. There's some publication from Lang et al. 7 enrolled patients were assessed for 14 days after mesenchymal stem cell injections. From this patient, the peripheral lymphocytes were increased, the C-reactive protein decrease, mean that the good prognosis, and also the overactivated cytokine secreting immune cells, CD4 T cells, CD8 and T cells, and NT cells disappear in 3 and 6 days. So mean that it will be effective to reduce. Also, intravenous transplantations of mesenchymal stem cell was safe and effective for treatment in patients with the COVID-19 pneumonia, especially with the critical ill severe patient. Yeah, I think this is a good one paper. This is good for us, especially for clinical nutritionists and also for everybody who work in this area. I think there is a central role of clinical nutrition in COVID-19 patients during and after hospitalization in ICU. I think oral, enteral, parenteral nutrition should always be carried out according to the patient conditions. In the case of hyperinflammatory patients, such as of the one affected by COVID-19. And it has been shown that the supplementation of amino acid helps to lower inflammatory state and promote normal physiological recovery. I think we need evidence base to prove this hypothetic. Okay, the guideline how that we can give when we start to give oral, enteral, or parenteral nutritions for our patients with COVID-19. First, we must know that how long that the patients will on intubations. If for less 48, I think no artificials. Artificials for more 48 hours. So we will give enteral, or it depends if there is a without or with contraindications. But if not, give as soon as possible. Intubation is over. Oral nutritions, not nutrition oral, and parenteral nutritions if there are contraindications for enteral nutritions. I think this is common things. Yes, this is some note that the researcher constantly readjusting clinical trial during pandemic. I think every institutions work hard to develop some clinical trials. And you know that the COVID-19 pandemic has severely disrupted the progressions of many clinical trials. 80% of non-COVID trials have been stopped because you know that numbers of patients decrease. And the key part in conducting clinical trials during pandemic and because of physical distancing, ensuring the safety of patient is the testing and treatment. And most of research changed to COVID-19 research. And some research shifting method like drugs delivery to home, in-person visit, teleconferencing, and rebuilding resilience protocols. Yes, not only for medical educations, also for research, we change or we adapt with the situations. And about the COVID-19 research is on full trust to fill in the gaps of the knowledge. COVID-19 addressing trial were fast-track and substantially address many inefficiencies. This is important because you know that what we call the reactive of us. Yeah, because we want to know, we want to look for what is the best treatment. Yeah, something like that. The unproductive. Okay, and then I think the rapid design and launch of clinical trial designed to research COVID-19, improving, modernizing certain aspects and practices of clinical trials, and then will benefit patient, practitioner, and all research. So we are, we need to we are waiting some clinical trials, and then also for vaccine clinical trial as well. And however, I think, yeah, hope so that it will be finished as soon as possible. Thank you for your attention.
Thank you, Professor Ari, for your presentation. Now we continue to our last speaker, our beautiful speaker, Dr. Jualita Surapsari. Please, the time is yours.
Okay, thank you, Dr. Dian. Okay, before I start, I want to say thank you to the organizing committee that gives the opportunity for me to be in this wonderful event. But first of all, I want to check, is my sound clear?
Yes, your sound is clear and your screen is clear too.
Oh, wait.
Auntie, can you actually open the door? I need this.
Okay, it's clear, Dr. Dian?
Yes, it's clear.
Okay, thank you. So good afternoon, dear professor and colleagues. My name is Jualita Surapsari. I'm the physician nutrition specialist from Pelni Hospital and Pondok Indah Hospital. It's been an honor for me to be here to see you in virtually in this symposium. So I was appointed to share about what shall we do to boost the immune system of people diagnosed as asymptomatic COVID-19. So actually, this is a quite important topic because in my small observation in my workplace, I saw a lot of people coming with non-respiratory symptoms, which is tested positive in the RT-PCR, such as a pregnant mother who come because of the early contraction, and then the surgical patient that was scheduled for having some procedures, and also the patient in the hemodialysis unit who come for the efficient repair. So I think this is a challenge for us to give the best for them, so they will not go into the symptomatic case. Okay, so this is the outline of my presentation today. And this is the global situation of COVID-19. Actually, this is already present in Prof. Ari slide before, that now we are facing more than 27 million confirmed cases up to now, since WHO has declared that this condition is a global pandemic. And we can see also from the graph that it's still in a rising mode, and we have to deal with this condition and help to reduce the complication of the disease. So the COVID-19 itself has so many clinical features, but if you look based on the severity, we can divide the patient into 3 stages. The first stage is the early infection, when the patient was detected positive from the RT-PCR. And the characteristic in this stage, patient only have mild to moderate influenza-like symptoms. And most of them also having the asymptomatic case. And then because of the risk factor, the unknown risk factor, they can go into the stage 2, which is called the pulmonary phase. This is the phase that patients commonly come for having help in the hospital. And then a certain percentage of people will get improved and resolved, but in a small percentage, they will drop into the worsening condition and drop into the respiratory distress syndrome and require mechanical ventilation. This number, for 48.9%, showing the patient that was initially diagnosed as asymptomatic COVID-19 developed symptoms later in the course of the disease. I derived this data from the systematic review and meta-analysis from the study in China and 16 other countries. And it was showing that nearly half of the patient that was asymptomatic may be still in the incubation period in the screening time. And they will develop symptoms later in the natural course of the disease. So it will raise a question to us. Why do some people get sick, but the others not? Of course, age and the comorbid condition possess an important part in this progressivity of the disease. So we have to give measures that can modulate the immune function of this asymptomatic patient so they will not develop symptoms later. So in order to implement strategies to modulate the immune function, actually we have to remember a brief pathogenesis of this COVID-19. So SARS-CoV-2 has an S protein that will bind into the cellular receptor. It's called ACE2. And then the virus comes into the host cell and then having a replication. While the virus comes into the cell, the antigen will present by the antigen presenting cell and will recognize with the T lymphocyte cytotoxicity and will damage. So from that, it will also stimulate the cellular immunity and humoral immunity. This is just a brief that COVID-19, the SARS-CoV, will bind to the receptor, bind to the receptor, the TLR receptor, and will induce the activation of the natural factor kappa B, and will induce the activation of the expression of interferon 1. So when we see the thorough inflammatory response of our body, we can see from this scheme that actually almost all of the micronutrients have a role in the response immune system. We can see here from the physical barrier and then the innate and immune response until the adaptive immune response, until the antibody is produced. They all need micronutrients to be involved in the person. So, based on pedoman tata laksana COVID-19 yang ada di Indonesia, the asymptomatic case patient would be advised to have a self-isolation at home or the appointed shelter by the government. And the management for this case, first, of course, symptomatically. And in this case, balanced nutrition is mandatory. And we can go back to the previous presentation by Dr. Reza in the morning, and also Dr. Lucy, that actually if we're not very sure that the person can have the nutrition intake as advised, we can give the oral nutrition supplements. Apart from that, we can also give the micronutrient supplementation, such as vitamin C, and then multi-micronutrient supplements, including vitamin C, D, E, and zinc. It is already well known that nutrition is the crucial factor in modulating the immune homeostasis. So, protein energy deficit and also a subclinical deficiency on micronutrient can impair the immune system of a person. So we have to make sure that we give the complete nutrition. Because of the novelty of the disease, it's a little bit difficult to find a formal recommendation for this micronutrient supplementation. But I try to find a review from, this is the review from Jayawardana et al. They recommend to give a supplementation such as a vitamin A, vitamin D, vitamin C, zinc, and selenium with the appropriate dosage. In this presentation, I will only discussing about the 3 micronutrients. The first is vitamin D. Vitamin D is assumed as a key intermediary between the innate and adaptive immune response. It has so many involvement in our immune response. First, the vitamin D will inhibit the dendritic cell differentiation and also the antigen presentation. And also, they will also increase the capacity of the macrophage to do their job in phagocytes. Now, we come to the suggested dosage. If we look in the recommendation that published by PDGKI, the Indonesian Clinical Nutrition Specialist Association, it was advised that we give the vitamin D for a person younger than 70 years old in the dosage of 600 international units per day. And for elderly, older than 70 years old, we give 800. But in the ASPEN, it's not clearly stated, so we just give according to the RDA. But if we look in another review, I found 2 reviews that suggested to give the dosage of the vitamin D 10,000 international units for a few weeks, and then continue with 5,000 international units per day. But they don't mention how many weeks that we give for the 10,000. And then the second micronutrient I want to discuss is a vitamin C. As we know that vitamin C is like a classic immunomodulator. We already know that we want to get sick, so we need to have another supplementation of vitamin C. Because vitamin C has so many roles in our immune system. Start from the neutrophil migration, and then increase the activity to phagocytes, and then it will also generate and proliferate the natural killer cell, and also for the proliferation of B and T cells. This is the suggested dosage for the vitamin C. From PDGKI, it was advised to give 1 gram per day orally for mild cases, which can we divide into 2 dosage, so 500 milligrams every 12 hours. For ASPEN, again, they only recommend for having it in the daily, in the recommended dietary allowance. But there is a consideration that we need to always remember, that the bioavailability on giving the vitamin C 200 milligrams, it is complete in the dosage of 200 milligrams as a single dose. But if we give a single dose of 500 milligrams and higher, the bioavailability will be declined, and the absorbed amount will be excreted in the urine. And it was also noted in the research that the oxalate excretion as a metabolite from vitamin C were elevated at the consumption of 1,000 milligrams of vitamin C daily compared to lower doses. So there are many types of supplemental vitamin C. The first, the classic one, is the ascorbic acid. If we want to increase the bioavailability of the vitamin C, so it's suggested to have the slow release formulation. And then we can also giving the patient in the form of the salt of vitamin C, such as sodium and calcium absorbate, which has which is a more readily absorption and excreted less rapidly than ascorbic acid. And the last one is the liposomal vitamin C, which is the greater bioavailability. The third micronutrient is zinc. There is interesting about zinc. If we look at the picture in left upper part, we can see the intersection between the zinc deficiency person with the high risk COVID-19 severity. So if we look at this, there is an intersection that we have to monitor closely about the intake of the zinc. Yeah, the first is elderly, of course, and then the obese person, and also the people with the comorbid. So this is the area that we want to address for the possibility of having deficiency. So when someone asks in the chat, do we have to give a supplementation for all the people? So we look for the high risk and the low risk people. Yeah. So for elderly with the comorbid, of course, we need to give a supplementation. Okay. So zinc has so many benefits in immune system. It begins in the antiviral process. If we remember, the zinc also has an important role in the healthiness of the cilia at the epithelial cell of respiratory tract. So zinc has its role from the start in the physical barrier maintenance, and then for controlling the response immune, and the controlling also about the inflammatory response of our body. So we'll reduce the inflammatory response in this COVID patient. This is the list of the trials that give the zinc as a supplementation, as a therapy, and also the prevention. We can see here that actually zinc would be giving more benefit if we give as a prophylactic, so before the infection happens. And this is the suggested dose dari PDGKI advised to give 20 to 40 milligrams per day, but from some systematic review, it was advisable to give until 150 milligrams per day. So as a conclusion, nearly half of COVID-19 asymptomatic case will develop symptoms in the natural course of the disease. So we have to take a clinical measure to prevent this asymptomatic case progressing. And one thing that we should remember, that dietary advice alone may not be sufficient to secure the nutrition adequacy to boost the immune system. So in this condition, a micronutrient supplementation is advisable. That's all, Dr. Dian, from me. I hope it can meet the expectation. Hello.
Hello, thank you, Dr. Jualita. Very nice presentations. We continue to the discussion session for the last webinar today. Dr. Marek?
Yes, hello.
Yeah, hello. There's two questions for you. The first question is, for patients who happen to survive from severe COVID-19, is there any reduce of lung capacity or may develop into COPD later, since there's a consolidation?
Okay, it's a very good question. I don't think we know exactly. The interesting things, the patients I have looked after, they seem to recover quite quickly. Even with the fibrotic changes, the recovery was within days. When we looked after patients with swine flu 10 years ago, their recovery was much slower. But we also know, and there's now some papers coming out, that patients who had COVID-19 disease and were ventilated, that their lung function is worse in the long term. So there is some effect, and we still have to wait because we only have now 7 months of experience, and we need to wait a little bit longer. But they seem to have faster recovery in the ICU and in the hospital after they were sick, but the long-term effect there seems to be going.
Okay, and if they are exposed to one more COVID-19, can they become worse for the?
Sorry, what's the question?
Yeah, if asymptomatic patients, if they are exposed to one more COVID-19, can they become worse than before?
Very good question. So there's only very few cases described where the patient were infected twice with the virus. And this type of virus is probably not the same because we know there's type A, type B, and type C of coronavirus causing COVID disease. So the patient who got reinfected probably were not infected with the same virus. That's number one. The other question is about the viral load. So if you are exposed to a virus and then you're exposed to someone who's got even higher viral load and your viral load then becomes worse, then obviously you're not going to do well. But that is very difficult to measure. And it's important to keep your immunity, as Dr. Juvalida was saying. If your immune system is good, you meet with the virus, you're asymptomatic, you're not very likely to develop a worse infection because your immune system will be able to deal with it.
Okay, so we have to have more attention for the viral load, yeah, and the immunity.
Maybe.
Okay, the last question for you, Dr. Marek. I want to ask to Dr. Marek, can people with silent hypoxia be detected with lung ultrasound? Are asymptomatic patients should be screened with lung ultrasound to predict the likeliness of worsening pneumonia?
Okay, that's a very good question. I think that asymptomatic patients should not, and nothing should be done to them unless we have treatment for asymptomatic patients. But if the patients present to hospital or to doctor and they ask the question, oh, can I go safely home or should I stay in hospital, then lung ultrasound should be done.
Almost.
So
Okay, thank you. Thank you very much, Dr. Marek. Prof. Ari, is there any comment from you?
Yeah, first about the, about the, what we call that, the reinfections. Because, I agree with Dr. Marek because just 6 months, so you're waiting, the condition of patient after years. So some report mentioned that the reinfections is mild than before, something like that. But it depends. I agree with Dr. Marek. So must to know maybe they have got suffer with another strain because that many strain of this virus that also here in Indonesia, something like that, and Jakarta virus is different with the Surabaya virus or something like that. So that's why maybe the clinical manifestation also difference between this virus.
Okay, so the type of the virus is okay. Thank you, Dr. Marek. There's a question for Professor Ari from anonymous attendee to Professor Ari. I'm sorry if this is not related to the topic, but since I cannot communicate with you, I would like to ask about the PEG, percutaneous endoscopic gastrectomy in Surabaya. PEG has expired to use Since the situations like this, we are not there to bring to hospital to change PEG.
Yeah, this is a thing. This is one of our problems. I mean, our problems for our patients, because they many reason they don't want to come to the hospital, especially for the patient as well. I just one case last week that almost 1 year. I mean, actually, almost 1 year, and then change the pack. The problem is if the condition of the pack. I mean, if it is more rigid, maybe it will hard to release this pack. This is one of the problems. And also it depends, I mean, the condition, if it is still work or not. But the important things, I mean, if this is your patient and consult to you as a clinical nutrition, please check about the conditions of the
Patient.
pack. Yeah, if it's more rigid, please advise your patient come to the gastroenterologist to change the pack. This
Okay.
is my comment.
Okay, thank you, Professor Ari. Now, next question. From your experience, how is the role of nutrition given to symptomatic patients, considering the virus itself is self-limiting disease, and the other therapy is symptomatic therapy?
Excuse me, is it for me or for Dr. Juwita?
For Professor Ari.
Okay. Yeah. Yes. Yeah. I think. Yeah. First of all, I think the important things for our patient is. Yeah. We need to eat. Yeah. We need to eat. Yeah. Something like that. Also, patients with asymptomatic as well. I think the important things that you must keep the nutrition is good for our patients, because patients with there will be decrease of inflammation. I mean, the stress of immune of our patient, and in these conditions, our patients need nutrition, the good nutrition. I think the important things, please give good nutrition for our patient, not only for patient but also for asymptomatic patient. Comment.
Okay, Dr. Jualita, you have any comments for this?
Absolutely agree.
Absolutely
Because
agree.
because sometimes the asymptomatic patient got overlooked by the physician. So sometimes we get this asymptomatic case by the calling of colleagues that ask that I have tested positive, so what should I do? Like that. And they are rarely come to the hospital because of only the positive result of the RT-PCR. So what we can do is giving advice to give a complete nutrition. That's all that we can.
Okay. Professor Narek, you want to comment about this?
Still mute.
Your voice is mute, still mute.
Sorry. What was the question? The nutrition?
How's the role of the nutrition since the COVID-19 is the self-limiting disease based on virus?
Yes, so as Dr. Jivalita said, it's very important to have good immune function. So all the nutrients that support your immune function and strengthen it, I think they're very good. And anything that is making your nutritional status worse and depresses your immunity is probably harmful. So if you have cancer, or if you have prolonged fasting or an unbalanced diet, you're more at risk.
Okay, thank you, Professor Nari. Last question for Professor Ari. Is it viable for taking and saving all recovered COVID-19 patients plasma to be given to severe symptomatic patients?
Yes, so we are still waiting the result of our study here in Jakarta, and actually we are waiting the result from Army Hospital as well, because they have completed the research. the theory mentioned that it will be effective, but sometimes it depends the condition of patient as well. So I think we are waiting the result of the study. But some publication from abroad mentioned that it will not effective to give plasma therapy. But I think it depends the case. I mean, if you are in severe case, and also the timing is also important thing. And I mean, beside to give placement plasma therapy, we still give antivirus and also other medicine for our patient. Not only just plasma therapy.
Plasma, okay. Yeah. Dr. Marek, do you have any experience for these questions? Your voice is still mute.
Sorry, convalescent plasma therapy. It has been tried. It so far has not been as promising as people thought will be, and we don't use it here. We'll have to wait for more data. I believe there's many studies coming out, especially in pediatric population, but also in elderly, and we'll see what that shows.
Okay, thank you for your comments. There's several questions for Dr. Jualita. The first from an anonymous attendee. I would like to ask about how to give high-dose vitamin C for patients having gastritis or the dyspepsia problem. Number two, how about probiotic for nutrient in COVID patient? Do you have any experience with this?
Okay, thank you for the question, Dr. Dian. So actually, for someone having a dyspepsia or a gastric problem, we can choose the vitamin C in the form of the salt ascorbate. So we can see in the supplementation, the form should be in a salt formulation, so such as like calcium ascorbate and then calcium ascorbate, because it will give more convenient to get. And we can give the dosage maximum at 200 milligrams, as 200 milligrams also the best dosage that can ensure that the bioavailability is complete. That's it. And then the second question about probiotic. Actually, I also try to find about the probiotic, but in the review, it's not always suggested to give a probiotic for the patient in the asymptomatic case. So if we can make sure that the diet is okay, and also we can make sure that they consume enough fiber, so it's not mandatory to give probiotic to the patient.
Okay, thank you for your answer. Professor Ari, I would like to ask about the vitamin C and the gastritis, since you're a gastroenterology consultant.
Yes, yeah, you know, because yeah, I think what we call that the most of our patients anxious with these conditions. So they try to look for what is the medicine that can prevent for COVID-19 or something like that. One of them is a vitamin C. So in my experience, I mean, since a couple months ago, so most of patients have problems after take more than 500 milligram. So I always recommend just take the dose below 500 milligram.
Yeah.
But it depends the condition of the condition of the dyspepsia of the patient. I mean, if the acute, maybe we can stop. But if the condition is good, so we can start to give the vitamin C.
Yeah. Okay. Thank you, Professor Ari.
The probiotic, I agree with Dr. Jualita.
Yeah.
So because you know the result of the study is not consistent, if it is work or not.
Okay. Thank you, Professor Ari. Last questions for Dr. Jualita. It should be for Dr. Luciana topics, but it's from Dr. Indria Chandra. How about the nutrition for patient confirmed COVID but with have no symptom? Should the supplement or other nutrients added to the daily menu or just eat anything as healthy patient? Thank you.
Okay, Dr. Indria, thank you for the question. So we should back to the our effort in giving the adequate nutrition. So if the patient has a less symptoms like only having a gastrointestinal discomfort and they can eat as advised, so I don't think we need to give something to the menu. Yeah, but if we think we consider that this patient will have a reduced oral intake, so we can prescribe a oral nutrition supplement. And then for the supplement that we can give to the patient without symptoms, first we have to classify whether this patient is in the high risk of having deficiency of one micronutrient or not. Just like I present in the zinc slides, we should see if the patient is elderly and then having comorbid, or the patient is obese, so we can consider of giving a selected supplement for them. That's all.
Okay, thank you for the answers. I think because the time is over, is already 4 o'clock. I should end this session. Thank you for Dr. Marek, Professor Ari, and Dr. Jualita for the nice session for this afternoon. I hope that the pandemic soon will be over, then we can meet with the real symposium next year. Amin ya. Thank you for all the speakers. Thank you, Dr. Marek. Thank you,
Thank you.
Professor Ari and Dr. Jualita. Okay, that's all for today's webinar. We really hope that all of you enjoy all of the session. We will see you again for the next 2 weeks on the webinar chapter 3 and 4. Thank you for all speakers, panelists, and committees. And thank you for all the participants for your interest and attention. I will return this webinar to the Master of Ceremony, Dr. Pitara. Bye. Thank you.
Thank you very much, Dr. Dian. Thus, we concluded the second session of Nutri Webinar Symposium 2020. We apologize if there is any question unanswered. We will try our best to send them via email. So our next session will be on Saturday, September 19th, 2020. See you all again next week. And as always, stay safe and healthy. Goodbye.